the pelvic floor issues. I know a lot of older ladies. I've had patients tell me that, when they go to the bathroom, sometimes they have to use their finger to stick things back up. Yeah.
Okay, pelvic organ prolapse. The bladder can fall, what we call a cystocele or anterior prolapse. The rectum can fall, which you often hear called a rectocele or a posterior prolapse. And it depends on if it's mild. We actually have grades depending on how far it comes out. It's mild, then it can be improved with pelvic floor physical therapy or a pessary, which is an appliance basically that gets fitted by your gynecologist to your vagina that holds things up almost like a little trampoline. And for some people who want to avoid surgery, that with some vaginal estrogen is perfect.
Hi, this is the Care Room with Dr. Cindy. Welcome. It's a space that was created just for you. I'm your host, Dr. Cindy, and this is a chance to get up close and personal with me. We're going to talk about the things in medicine that matter to you. We'll talk about the questions you've been carrying. We're going to have some honest conversations. We're going to hold space for joy, struggles, and everything in between. It's care that goes beyond the exam room. Care you're going to take home with you, whether you're listening while you're driving or you're listening while you're exercising. I promise that it's going to be care that's rooted in truth and a deep commitment to walking with you every step of the way. I'm glad you're here.
Hi, everyone. Welcome, welcome, welcome to another episode of the Care Room with Dr. Cindy. I have a very, very special guest. I know I say this every time, but this one is extra special. It's Dr. Carolyn Moyers, and she's with us today. She's an OBGYN who's here to talk about something that I'm sure a lot of us ladies would love, love, love to pick her brain about. So before we get into it, I'm going to let her introduce herself. Dr. Moyers, all yours.
Thank you, Dr. Cindy. I'm Carolyn Moyers, board certified OBGYN, menopause certified provider, and ISHWISH fellow. That's International Society for the Study of Women's Sexual Health.
Ooh.
And I did not know anything about sexual health really, other than, we make babies. And so as I opened my own practice, which is Sky Women's Health, I'm the founder and CEO of Sky Women's Health. And when I opened my practice, women were like, oh my gosh, you're not going to be delivering babies. You're here for me. This is when perimenopause and menopause started coming through the doors. And I had to beef up my education. And so I got menopause certified. And then what comes with that is all the sexual health concerns that arise. And I did not feel adequately prepared to treat that. We get very little education in sexual medicine. And so went to my first ISHWISH conference and learned so much. And I take every course I can get my hands on and go to the conferences. And so eventually applied for their fellowship and continue to learn from the global community. It's just really phenomenal. So I host Sky Women's Health podcast as well. My everyday now is all about perimenopause and menopause and sexual health. And I absolutely love how my career has just kind of shifted over the years. This is such a fun phase.
It sounds like it. So I am going to be asking all the questions a lot of us are out here, have. And guys, it's going to be sexy talk, okay? So she is sex medicine certified. So Dr. Moyet, a lot of our audience, busy moms, they're on the go. A lot of them are older, raising, teenagers. They're getting to that stage where they're having trouble sleeping. They're having, hot flashes. One time they're hot, one time they're cold. The covers need to be on, they need to be off. We're not sure if we're turning on the heat or the AC, where I was jokingly telling her before the show, like we're having this stubborn fat that just won't go away, and sometimes it's in the belly. So can you tell us more about that phase of life? If you can just break it down for us, because so
Yeah.
many of us suffer through. And I know
Yeah.
that's a big thing now about not suffering through it. But let's start with telling us about that phase of life and what we can expect.
Sure. So it's a universal experience, right? If we live long enough, we're all going to experience menopause. 1.3 million women enter menopause each year. That's about 6,000 women a day. The average age is 51, 51 and a half. Most go through menopause between the ages of 45 and 55. But perimenopause, the 7 to 10 years leading up to the final menstrual period, right? That menopause is defined as your final menstrual period, 12 months after your final menstrual period. Well, a lot of women are like, well, what if I had a hysterectomy or I've had an ablation or I have a progesterone producing IUD and I'm not having a period? Well, you can get an FSH level on 2 occasions, 4 weeks apart. And if they're elevated, it's consistent with menopause. But if you're having symptoms, it doesn't matter whether it's at perimenopause or menopause, right? The difference is the pesky period and the potential for pregnancy. That's the only difference between menopause and perimenopause. Those periods are still happening. And in perimenopause, we may see them become longer or shorter, more frequent, less frequent, heavier, lighter. They can be all over the place because our hormones are fluctuating so erratically. You probably remember seeing the charts in the doctor's office where you see this beautiful graph of like the rhythm of our hormones,
Yeah.
right?
Yeah.
Each month they do the same thing over and over and over again. Well, in perimenopause, it looks more like the Dow Jones chart. Like you can't make sense of what's going on. And it's super frustrating.
Sure.
Also, because 94% of women report never being taught about menopause. So we feel clueless about this puberty in reverse and what is actually going on. The symptoms look very similar and it affects all of our body symptoms. So when we talk about vasomotor symptoms, that's hot flashes, night sweats, heart palpitations, increase in blood pressure, mood, sadness, overwhelm, depression, agitation, irritability, trouble concentrating, trouble with memory, lack of drive, decreased sex drive, musculoskeletal, you have bone loss, right? We see more osteoporosis or osteopenia, muscle loss, joint pains, frozen shoulder, arthritis, changes in fat distribution, sleep, difficulty falling asleep, staying asleep, fatigue from not sleeping, GI, we can have bloating, abdominal weight gain, gas, constipation, heartburn, and then of course, vaginal health, vaginal dryness, painful sex, urinary urgency and frequency, and more frequent urinary tract infections. So it's affecting us from head to toe.
Absolutely. Absolutely. Yeah, it is. That brings me to because the questions I know our audience wants, and you're the perfect specialist for this. So, why is sex so much harder during the perimenopause menopause um period? No, seriously.
Yeah, this is a great question.
Yeah.
So it's harder when when we're not feeling ourselves, right? When we're not feeling ourselves, when we're hot and we're irritated and we're overwhelmed and we're not getting any sleep and we're over caffeinating to compensate for the lack of sleep and then we can't fall back asleep. We're going to choose sleep every time, right? And if you're in this long-term committed relationship, it's much more common to have a responsive desire, not the spontaneous desire that we see in Hollywood. That that's not typical in the 20-year, 30-year relationship. So you know what that's like. You've been there, done that. And so some novelty is important, but a lot of it is women just not feeling themselves or having a dry, painful vagina. So many times this week, I've seen patients who originally thought that they had hypoactive sexual desire, just zero desire for sex. Guess what? We fixed the dry vagina. Sex isn't painful anymore. And all of a sudden, they're back in the saddle. They're feeling
Yeah.
good. So they're like
Yeah.
that. Yeah, that's not a problem anymore because it doesn't
Yeah.
hurt and we don't desire things that are painful. And
Yeah.
so
Yeah.
every vagina loves estrogen and vaginal estrogen is safe for every body. It's also safe for breast cancer survivors. We have studies showing time and again that it does not increase incidence or mortality from breast cancer survivors. So it's absolutely safe with typical use. It's not systemically absorbed. So this is local intimate skin therapy. This is not going to affect your hot flashes or your night sweats or your moodiness.
Okay.
This is specifically for vaginal health. And I would
Sure.
say 40 to 50% of my patients actually need both systemic hormone therapy and their local intimate skin therapy with the vaginal estrogen, a little moisturizer, lube for any penetrative sex.
Right.
But also, relationship aspects come into this, right? If we're not happy with our partner, we're frustrated with our partner, we've got some resentment, or we have, thoughts about how we were taught about sex, or now we have teenagers in the house, whereas before when you put a baby down to sleep, you can sneak away and feel guilt free, but then you've got teenagers in the house, so you're scared they're going to catch you. There's so much complexity to it that it just gets a little more complicated.
Absolutely, absolutely. But tell us more about the vaginal estrogen. Can we get that? I go to my PCP and get that? How, for the women out there who are like, yes, that's me. It hurts when I have sex. I don't have the drive. Do I have this hypoactive sexual drive versus does my vagina just need more estrogen? How do I get that estrogen?
Yeah, it is a prescription.
Okay. So,
So yeah, you need to get it from your provider. Yeah,
okay.
it is a prescription. And it comes in many forms. So it's not just vaginal estrogen cream because some people feel like that's entirely messy and they can't
Yeah.
stand it. So it's also available in a tablet, in a suppository, in a ring, and there is a vaginal DHEA, which is a precursor to estrogen and testosterone. That's a nightly suppository, which is great for individuals who have postmenopausal painful sex.
Yeah. So I have had patients tell me like they can't keep the suppositories in. Have you heard that at all? Yeah.
So they may not be putting it in far enough.
Okay. Okay.
Yeah. Or they may have some prolapse, and that's a whole other issue, right? We
Okay.
need to get
Got
that vaginal estrogen there.
it.
And so this is where we trial and error, right? I usually say we have to be brave enough to try. Like you don't come with a manual. I don't know exactly what's going to work perfectly for you. We just have to be brave enough to try one. And with the vaginal estrogen cream, I can usually get patients to use it. There's a couple of barriers, right? So one is it comes with one applicator and people aren't jazzed about reusing this applicator for the next 90 days, even if it's only 2 nights a week. Want to worry with having to clean it. They don't want to get their bottle brush out or their straw brush and try to go after it and clean it. So I will have patients actually just order the disposable vaginal cream applicators for off of
Okay.
Amazon for a single use application.
Okay.
Might also have them just use it to draw up their 1 gram if that's their dosing and put it on their finger and then use their finger, put it in kind of like a tampon applicator and rub it.
Yeah. And I've had patients say when they use the finger, that works better. For the patients who are saying, I've been hearing about this black box warning. What do you have to say about that, Dr. Moy?
Rip it up. It's trash. So if you didn't see, several of our brilliant colleagues
Yes.
went and spoke to the FDA
Okay.
about this and removing the black box warning on vaginal estrogen because that information that's on vaginal estrogen is extrapolated from oral estrogen and doesn't apply to low dose local therapy. So there is no increased risk in stroke or heart attack or cancers when using vaginal estrogen.
Absolutely. Guys, you hear that? Vaginal estrogen is okay. It's okay. You heard
And
it
if
from
one doesn't work from you, then we're going to try another option, right? We're going to try one that works best for you. And so if you don't like the cream, let's try the tablet. If you don't like the tablet, let's try a suppository. If you don't like the suppository, the vaginal ring is a really awesome. And I'm sorry, I'm not at my desk, but I have all the samples. So
Sorry,
the
madam.
vaginal ring, you just compress it and pop it in and it sits up near the cervix or at the top of the vaginal cuff and releases your estradiol daily. So it's pretty awesome device. We have a low dose specifically for intimate skin therapy. And then we have a higher dose ring that is for the vasomotor symptoms. So it's a high enough dose that it'll get systemically absorbed. But what we're talking about specifically is just that vaginal health.
Yeah. Yeah. And for my patients who, when I talk about, "Oh, we probably should also test your testosterone," like, I'm not a guy. Why are you talking to me about testosterone? Um, your thoughts on that?
Yeah,
Yeah.
so women also make testosterone. It's a human hormone.
Yeah.
So it's not just female or male specific. It is a human hormone. I will say that saliva testing and urine hormone. So testosterone is a human hormone. Men and women make testosterone.
Absolutely.
It's been gendered, but we absolutely make testosterone. Now, when we think about hormone testing, women often come in and say, "Oh, I need my hormones tested." Well,
Yeah.
in perimenopause Hormonal testing generally isn't helpful, and saliva and urine hormone level test is expensive, it's not accurate, and it should not be used to evaluate or treat your symptoms. So blood test is where it's at. However, in perimenopausal women, I often say, hormone testing isn't super helpful because we're unlikely to catch those hormones misbehaving. Remember, we talked about how much they fluctuate. So we really look at labs in regards to unearthing underlying causes that could be masquerading as perimenopause. For instance, diabetes, insulin resistance, thyroid disorder. There's, iron deficiency, vitamin D deficiency. There's so many different things that could contribute to your symptoms. And so we like to make sure that we're not missing an obvious underlying cause. And so that is where I take labs and see where we're at. If we are not having a cycle because of a hysterectomy or an endometrial ablation or a progesterone producing IUD, and patients are curious, then sure, we'll get an FSH on 2 occasions, at least 4 weeks apart. Now, if patients really want their hormones tested, we love data points, right? There is no harm in getting their hormones tested. Sure, let's get it. Let's see where we are. And, sometimes it's validating and sometimes it's like, oh my gosh, what happens so often is that they get their labs done with their PCP, or they go to the endocrine and they see the endocrinologist, maybe even the orthopedic surgeon because they've got some frozen shoulder going on, until somebody says, maybe this is menopause or maybe this is perimenopause. Or they hear, your labs are normal and they're told, well, you're fine, you're normal, or you're too young, or it's all in your head, or using hormone therapy will just delay the inevitable. These are things that patients often hear, and it's just not true. You can start treatment even in perimenopause.
Yeah. So, can you tell us more about the correlation between low estrogen and getting frequent UTIs, especially in our older ladies? Yeah.
Okay, sure. With estrogen deficiency, so what we were talking about earlier with the vaginal changes, right? We were talking specifically about the vaginal health, vaginal dryness, painful sex, urinary urgency, frequency, more frequent urinary tract infections. This is due to estrogen deficiency, and we call this genitourinary syndrome of menopause. Okay. So with a lack of estrogen, the vaginal epithelium actually starts to change. The walls start to thin. We start to lose folds. The urethra becomes more prominent, and the bladder and the bowel are condomates. They share a wall. And so if we give back vaginal estrogen, we resolve these symptoms. So it's much more than just sex. I had a woman in her 60s who came to see me after being admitted to the hospital with sepsis, seeing urologists, being back and forth, back and forth. Nobody ever put her on vaginal estrogen, and she was up and down to void all night long to the point there was suicidal ideation. We put her on vaginal estrogen, symptoms gone. She thought it was a miracle worker. It's vaginal estrogen. She's the queen. She's the queen.
I love it. I love those stories. Oh my goodness. Amazing. Amazing. So, Dr. Moyers, for those of us struggling with the weight that we just can't get off, and there are these newer medications, Zempic, Wegovy, Zepbound.
Sure.
What are your thoughts about weight loss, menopause, or the perimenopausal?
Yeah, what our body once put up with in their 20s and 30s, she's not having anymore. This is where lifestyle really comes into play, but it is so much more than, fewer calories in than calories out. It's so much more than that. You know, Lifestyle changes are really important. Practicing mindfulness, a whole food diet, prioritizing your protein, avoiding processed foods and added sugars,
Those are not the things
exercising.
I want to hear.
I know. Like, we cannot escape it. There's not a magic pill, although,
Okay,
Ozempic.
but say estrogen.
Yeah.
Estrogen gets
Yeah.
rid of my belly fat too.
Well, okay, it's much more complex than that. But yeah, so I'm starting with lifestyle changes, Dr. Cindy. So we're not going to escape lifestyle changes. So exercising with the emphasis on weight training is really key because we lose 0.6% muscle mass annually. Well, what happens when we have less muscle? We burn less calories. We put on more fat. So weight training is really important in this phase of life too. And then, prioritizing sleep is so important, which is really hard if we're having hot flashes and night sweats. That's disturbing our sleep, right? So this is where your estrogen comes into play to really mitigate those symptoms. And when we get our symptoms under control, a lot of times our metabolism is then humming at a different rate and we're doing better. We have more energy, more drive. We're making better food choices because we are getting better sleep. And so it all kind of interplays. And we do know that individuals who are on GLPs, now we have a small study showing that individuals who are on GLP and their hormone therapy actually lost more weight than just on GLP alone. So there is some promise that, doing all the things is effective, but I wouldn't say that there's one easy button.
You just burst my bubble, but
I'm
thank you.
sorry. I'm sorry. That's why as part, like my patients, we have a weight wellness program. We have two options. We have a weight wellness program through Holist, which is a phenomenal program. That's a lot of education around our dietary needs and exercise and helps them to kind of reframe their brain around eating. And that's a 12-week program. I did it and lost 10 pounds. So I know it's possible for patients.
Yeah.
And then we also have the option of working with a nutritionist where they do a 2-hour intake and really deep dive because a lot of us want to eat better, but we just don't know how.
Sure.
And our food industry has made it so incredibly easy for us to eat a horrible diet. And we need anti-inflammatory foods. We need whole foods. And what we're currently consuming can be really a challenge. So I love to incorporate that because we all need a little extra support.
Yeah, absolutely. Absolutely. I want to swing back to vaginal health and sexual health as well. So, for those listening, because I get a lot of questions as a primary care doc, douching,
Sure.
douching, do you
No,
guys recommend? Exactly.
no.
Yeah.
No.
Can you explain
So
why?
the
Yeah.
vagina has a natural microbiome. She likes to be acidic. Vaginal estrogen helps you to preserve the acidity. If we get that microbiome upset, we can get recurrent infections like bacterial vaginosis, which tends to be very challenging to resolve, or recurrent yeast infections, or we're more susceptible to sexually transmitted infections. And so, yes, we say no to douching. She has a natural cleaning oven. Leave her alone.
You heard that, ladies?
She's a
Leave her.
self-cleaning oven.
Oh my gosh. And then I know there was this trend or this fad going around about putting yogurt up there. Have you heard about that?
I've ignored that. I mean, yes, kind of on the periphery. I think because it's a probiotic, look, you can take probiotics by mouth. Like it's unnecessary to put in your vagina and potentially cause other problems. Stay away from the aisles and the CVS and the Target and the Walmart. Stay away. You don't need any of those products. Usually will land you in my office. The vulva needs nothing more than soapy water to the hair bearing areas and water to the labia minora.
Okay. Which brings me to another question I get frequently. Hair? No hair. What is healthier?
Personal preference. I mean, it wicks away moisture, but it's really just a personal preference. Women constantly apologize for being
Yes.
sweaty or for not having shaved and
And I'm like, that's the
no
last thing.
judgment.
Exactly. I'm paying
Zero
attention.
judgment. Zero judgment. It is totally your choice.
Yeah. Yeah. And then for those ladies, because I that was another question that had me stumped. Someone asked about, I guess, when she was having sex, it's like gas would come out. She would hear those sounds. Is that possible at all? And then you start thinking like, is there a fistula or something? But that's me. But talking to the gynecologist, she says like whenever
Yeah.
she's having
Yeah.
sex,
So
she hears
that could be something that could be resolved with pelvic floor physical therapy, likely. It may just be some laxity over the years, whether it's from weight and or just pelvic pressure from carrying babies or birthing babies through the vaginal canal. So definitely merits a gynecologic exam and see if there's something there.
absolutely. And Dr. Moyers, for for those with the pelvic floor issues. I know a lot of older ladies. I've had patients tell me that, when they go to the bathroom, sometimes they have to use their finger to stick things back up. What do you recommend?
Yes.
Yeah.
Okay, pelvic organ prolapse. Okay, yes. So the bladder can fall, what we call a cystocele or anterior prolapse. The rectum can fall, which you often hear called a rectocele or a posterior prolapse. And it depends on if it's mild. We actually have grades depending on how far it comes out or pushes down, depending on different grades. If it's mild, then it can be improved with pelvic floor physical therapy or a pessary, which is an appliance basically that gets fitted by your gynecologist to your vagina that holds things up almost like a little trampoline. And for some people who want to avoid surgery, that with some vaginal estrogen is perfect for them, right? They avoid surgery, they avoid the pelvic pressure. Some people have difficulty taking it out themselves, and so they may elect just to come back to the gynecologist every 3 months to have it removed and cleaned and have the vaginal walls checked to make sure there's no erosion and then have it put it back in. And then if it's significant enough, if it's pushing out of the vagina and you're not able to hold a pessary, then obviously this is when surgical intervention is recommended. And so that would be done either with a urogynecologist or a urologist who's well versed in pelvic health. I'm sorry, in female pelvic health. I mean, urologists do pelvic health.
And then back to the questions I get a lot. Underwear at nighttime? No underwear? You said she's like a self-cleaning oven. Have you heard that one?
Yeah, I think that's a personal preference.
Again, okay.
Yeah, yeah. I mean, I don't think we don't have any data on like one is better than the other, but some people are a fan of letting her breathe. That's fine.
Okay. And then another one I get is vaginal odor. And how do you keep it clean? I know you said she's a self-cleaning oven, but anything you recommend for
Yeah.
I
So are
know
we so I know that
sorry, I know that's a deep topic because there's pathological odor and everything else, but
yeah,
yeah,
right.
sorry.
So if we're just in midlife and noticing like more odor and kind of bothered by the odor, that could be just, the changes in sweat glands, etc. Maybe we're sweating more. And so, just antibacterial soap to that region, the hair bearing regions, not the vulva. We don't need to put any soap inside of the vagina or the labia minora. Vaginal estrogen is going to help to preserve the pH and maintain so that we're not noticing as much odor. And then if it's something that's persistent for 2 weeks or more, we need to get evaluated to see if there is an infection, especially if there's any itching or burning or increase in discharge associated with it.
With it. Absolutely. Guys, you heard her. You heard her. So, Dr. Moyers, how can we find you? They listen, they love your sense of humor. They love, how you describe things and talk about things, and they just love you. How can they find you?
Yeah. So an easy place to find me is at Sky Women's Health Podcast. This is where I put a lot of information, a lot of heart into disseminating information for patients to empower them to be their best healthcare advocate. Because I realize not everybody's in the Dallas Fort Worth area in Texas and going to come see me. So I want to empower you to know how to advocate for yourself, whether you're considering, do I need birth control or do I need traditional hormone therapy and perimenopause? Topics like that. If you've got a question about it, we've probably done a podcast episode on it at Sky Women's Health Podcast. And that's also the name of my practice. And you can find me on the social channels, Instagram and Facebook at the same handle. And it's Sky Women's Health, of course.
Yeah. And the podcast, where can they watch those videos? Is it YouTube? Is it Apple Podcasts? Yeah.
Yeah, everything goes on Spotify and Apple and a couple of other platforms. And a lot of my stuff is on YouTube, but not as it is consistent now, but only in the last couple of months. So you might not find all the episodes there.
Okay. Okay. Guys, you heard it here. The wonderful Dr. Carolyn Moyers. And I am going to bring her back because I have lots of questions that I'm hoping she answers on different topics as well. But until next time, we'll have another wonderful guest with us next week. Take care. Bye.
Thanks for spending time in the care room today with Dr. Cindy. If you liked what you heard, please subscribe, share this podcast. I'm also on Facebook and Instagram. You can follow me there. Remember, you're not alone in this. There are doctors who do care. The information in this podcast is for educational and informational purposes only. It is not a substitute for professional medical advice. treatment, or diagnosis. Always, always consult your personalized healthcare provider for medical guidance.